Welcome to part 2. Hi, I'm Jerry Hesch, a physical therapist at the Hesch Institute in Henderson, Nevada, very close to Las Vegas, Nevada. And this is part 2 of this poster presentation titled Pubic Joint Dysfunction and Symphyseal Diastasis, a novel biomechanical and treatment model. And this poster was presented at the American Academy of Orthopedic Manual Physical Therapy in Cincinnati on October 19, 2013. So this is part 2, and we are continuing right here on the topic of diathesis recovery. In order for the pubic joints to come back together to approximate and heal, it is necessary, in the cases of a birth trauma affecting the pubic joints, it is necessary to reverse those faulty movements in the pelvic joints. And you need to reverse those trajectories, otherwise healing simply cannot happen. A basic fundamental understanding of orthopedic medicine is that for a joint that has become unstable, a bone that has broken, in order for those to heal, they need to be approximated near their normative anatomical position and then maintained there for a period of time. But in these cases of a traumatic separation, you can't simply put a compressive belt around that pelvis and hope for healing. You actually need to move the hemipelvis forward and medially. The same as in this example, you would need to move the hemipelvis forward on each side, the ilium moving forward on the sacrum, and then you would work on getting the compression at the anterior joint surface. And in truth, the back of the joint would actually separate a little bit because it is normatively wider behind the joint. Okay? So following normative orthopedic healing principles, that's what we would like to accomplish. So it is theorized that a symphyseal gap may persist in those cases that fail to fully recoil and heal, such that in the chronic population of obstetric pubic symphyseal diastasis, orthopedic manual physical therapists might be able to evaluate and identify a lack of anterolateral glide of the ilia or hemipelvis, and also a lack of medial compression at the ischiopubic joint. So there should be an ability, and this is in fact what I do with these clients, an ability to evaluate movement and stability in these directions. And I am speaking of specifically evaluating an anterior glide movement of the ilium on the sacrum. And so the client is placed in very stable positions where a force directed in the plane of the joint through the hemipelvis is imparted, and that can also be tested at the flat part of the ischium, and you can also evaluate stresses at different bony parts, including the pubic joint itself. So if the manual therapist is to evaluate those movements and those forces and find that there is a significant restriction, then by applying a small force for a very long time, we would hope to induce very gentle, safe movement to restore fairly normative positioning, at which point we would then move on to adding a compressive SI support, which we will talk about very soon. So now we're going to talk about the pelvic support. And this support, in this picture, you can see the person's hands. You can see that it's worn fairly high. It's just a couple of inches below the belly button. And this demonstrates a lower application where it is applied across the true hip joints. The bump on the outside of the hip is called the trochanter, right outside the front pocket, which also happens to be in line with the pubic joint. So looking at the anatomical model here, what the research suggests is for this kind of an injury, it would be wrong to apply the belt up here, where it typically is applied for sacroiliac joint dysfunction. Instead, it should be applied down low where the forces are across the true hip joints and also across the pubic joint, because again, it is the pubic joint that has the primary instability, not the sacroiliac joint. And there's a tremendous amount of marketing going on for sacroiliac joint dysfunction, and sadly not enough awareness in the community about pubic joint dysfunction, which in these examples is of greater concern. So we're going to talk about now about the trochanter binder replacing a sacroiliac joint, and this is based on very good orthopedic research. The trochanter pelvic belt is an orthopedic standard of care for acute obstetric pubic symphyseal diastasis. Note that significant compressive reduction has been reported to occur in the acute phase in a very short period of 4 days. So in this example, come down to this one please, figure 8, and it's a little bit dark, and I apologize for that, but this shows the pubic joint in someone who is, the sacroiliac joint. The arrow points to the SI joint, and it got compressed in 4 days by wearing a trochanteric belt. Down here you see this tremendous separation of the pubic joints, and over here you can see very narrow joint space. I hope that you're able to see that with the video. If not, I will then post that up separately. But within 4 days they achieve significant compression, and of course it will take then weeks to months for the scar tissue to fully take hold and create the intrinsic stability of the joint, and of course strengthening would also further that process. So we know that in this example, where was the belt applied? It was applied low. It was applied at the trochanters. We'll get to the research very shortly. Research indicates that typical application of the pelvic or SI belts above the trochanters is not as effective as the application directly across the hips, across the trochanters. And now we're about 3 to 4 inches below the belly button. In physical therapy and rehabilitation literature, placement is not usually specifically reported, and studies can be inconclusive. Because this support typically is referred to as a sacroiliac support, the nomenclature implies placement at the level of the sacroiliac, above the waist, above the trochanters. In addition, much of the advertising for various sacroiliac supports advocate the higher placement without acknowledging the possibility of primary pubic joint dysfunction or primary obstetric pubic symphyseal diastasis. So you can see that there's an education gap here. Placing the support at the trochanters is superior regarding biomechanics and the amount of therapeutic force. Cadaveric studies using force transducers validated that up to 40% greater compression occurs in the pubic joints and sacroiliac joints, and the force is directly in line with the pubic joints. And there are 3 different scientific references here. And here's a picture of the pelvis here. And this is an apparatus that was put there, and they used a measuring tools called force transducers, and they measured it at 3 levels. First level was worn up high here, and then the second level was a little bit lower. That's level 2 there, and then this is level 3, right in line with the trochanters. And so this really is the location. It's a very simple concept, yet most of the time people that use an SI belt wear it very, very high up. And again, if the pubic joint dysfunction is primary, it really should be worn lower down. Okay? Simple concept, but we do need research to tell us what to do, and the research makes that very, very evident. A more comfortable application using less pressure, yet receiving greater compression, is then accomplished. The typical higher SI application below the waist actually replicates joint instability because it reproduces those very forces. Remember, when someone's pregnant and the baby's growing in there, and the pelvic joints start to get lax. They start to spread in this manner in preparation for birth. Well, if you wear the SI belt up high, guess what? You're compressing there and using the same kind of forces. Okay? I feel like I'm getting a little bit repetitive, but it is an important concept. Now, I'm not here to negate the value of an SI joint support. So in someone who has a trauma that primarily involves the sacroiliac joint, then this is in fact an appropriate placement. So I'm not stating one versus the other. I'm simply stating that in the presence of a primary pubic joint dysfunction or a pubic joint diastasis, that's when you need this kind of an application. When I see clients, my preference is to let them try it here and then let them try it there and let them decide. And it could be that because of different joint configurations in different individuals, it may well be that this is an appropriate application for some with pubic joint dysfunction or diastasis, whereas most of the time this is. So the bottom line is that we need to pay attention to individuals, and for that reason I test both placements. So it is hoped that educated patients and informed clinicians will increasingly promote test and retest pelvic support placement for primary pelvic joint dysfunction or for mild to severe obstetric pubic joint dysfunction. So let me get to my concluding statement, please. The orthopedic trauma research enhances the understanding of orthopedic manual physical therapists in how they can evaluate and treat pubic joint dysfunction and traumatic symphyseal diastasis, which would obviously be in the subacute phase, and the same for obstetric pubic symphyseal diastasis. Ideally, improved early diagnosis and intervention for pubic joint dysfunction and for non-surgical obstetric pubic symphyseal diastasis and traumatic diastasis may facilitate successful rehabilitation. Additionally, hands-on stress testing, spring testing may conceivably identify cases of occult instability. Novel interpretation of biomechanics may predict novel intervention, and here we're speaking of that posterior glide migration of the pelvis. You could also describe it as forward migration of the sacrum. Mobility and stability testing is worthy of exploration in the chronic pubic joint and traumatic and obstetric pubic symphyseal diastasis population. This theory seems promising, and clinical research is needed to determine if this model has clinical validity and utility. Orthopedic manual physical therapists may have much to offer to the non-surgical population who suffers from pubic joint dysfunction and obstetric pubic symphyseal diastasis. This has also been posted very briefly on YouTube, and there are a couple of videos, in other words, that describe the problem of symphyseal diastasis. And again, this was a presentation, a poster that was presented at the American Academy of Orthopedic Manual Physical Therapy in October 2013 in Cincinnati. The title was Pubic Joint Dysfunction and Symphyseal Diastasis, a Novel Biomechanical and Treatment Model. I'm Jerry Hesch from the Hesch Institute, and proud to sponsor this work for persons who suffer with this. And it's primarily a female problem, but you do have males who in a car wreck or severe trauma sustain similar injuries, and I believe that we can improve evaluation and treatment for those clients. Thank you very much.